Welcome to today's webinar, Trends in Asthma Care, a learning opportunity for patients and caregivers. Today's webinar is being recorded. All participants are in a listen-only mode. There will be an opportunity to ask questions today. To ask a question, you'll want to type that into your question into the Q&A field and click Submit. You may need to open up the Q&A box onto your screen, and it's located in the tray on the upper part of your screen. It is my pleasure to introduce Cindy Trubisky, National Senior Director for Asthma Programs at the American Lung Association. Cindy?
Well, hello. Thank you so much for joining us on today's webinar, Trends in Asthma Care. It's my pleasure to welcome you today. Let me just go to the right slide. There we go. I'm the National Senior Director here for asthma programs at the American Lung Association, and I'm so happy to be here with you today. My pleasure to serve in this role in our mission department, and I'm so encouraged that we have so many people here to join us today, a great turnout to learn about asthma. So today's program is designed to provide you with more information and knowledge about the different types of asthma, new and upcoming treatments in asthma management, and then tools and resources from the American Lung Association to help you better control your asthma. So we endeavor to share some of the new and upcoming cool asthma stuff out there in the world. It'll be important for a lot of people managing asthma on a daily basis. So this means new types of asthma and personalized or precision medicine, new ways to monitor control of your asthma, new therapy options such as medicines, and new ways to administer asthma treatments, as well as those resources I mentioned to help you along the way. We hope you'll find this a meaningful use of your time, and from the team and the American Lung Association, we thank you for attending today's program. If you have any questions or suggestions on how we can continue to improve the program, we definitely welcome that. And as Barbara mentioned, we welcome your input and your questions in the question answer mechanism. Okay, so let's launch. You're in great hands today with this presentation. Barbara Kaplan and Dr. Jered Weinstock are here to guide you through this new content. So I will now introduce our guest speaker for today, Dr. Weinstock. He is a welcomed and respected expert in the field and a notable volunteer to the American Lung Association on numerous occasions. So we're so thankful to have you with us. A little intro to Dr. Weinstock is that he's a pediatric pulmonologist at Providence, Alaska Medical Center in Anchorage, Alaska. He earned a bachelor's degree in biochemistry from the University of Scranton and a medical degree from American University of Caribbean School of Medicine. He completed a pediatrics residency at K. Hovnanian Children's Hospital in the Jersey Shore University Medical Center, where he was selected as a 2018 recipient of the Nurse's Choice Physician of the Year. Love that award. After his residency, Dr. Weinstock completed a pediatric pulmonology medicine fellowship at Children's National Hospital in Washington, D.C. His research interests include prematurity and the respiratory epithelium, and his clinical interests are asthma, cystic fibrosis, ventilator management, neuromuscular disorders, and bronchopulmonary dysplasia, among others. So in his leisure time, Dr. Weinstock reports he's an avid traveler, enjoys hiking, biking, and running. So I will now turn the presentation over to Dr. Weinstock to start us off. Welcome, Dr. Weinstock. Thanks for being here.
Thank you so much for that great introduction. And yes, it is a pleasure to be here on behalf of the American Lung Association to spend time today in this next hour discussing asthma and, of course, answering any questions that anybody may have. So I am just going to take over here in terms of the slides. Cindy or Barbara, I did press take over, but I'm not seeing the slides right now.
Okay, 1 second. Let's see if I can help out here. Mhm.
And I also have them too, if you needed me to share my screen.
Yeah, let's see. I actually don't see the option myself to take back control. Let's see.
If you'd like, I can try to take control and see if Dr. Weinstock can take it from me.
Yeah, thanks, Cindy.
Let's see.
There we go.
All right, you see it, Dr. Weinstock?
Yes, I see the take control. Let's see.
There
It
you
should,
go.
yeah, there we go.
Excellent.
Okay, I think we are ready to go. So again, yes, thank you for having me. It's a pleasure to be here again on behalf of American Lung Association. We have a lot to talk about today regarding a lot of the newer trends in asthma diagnosis, workup, and treatment. And of course, again, we'll be spending some time answering any questions that come along the way. So in terms of defining asthma, let's look at this slide here in terms of where we came from and where we are right now. So you can see this evolution here beginning in the early 1960s, whereby the American Thoracic Society characterized asthma as an episodic disease with reversible airway constriction and increased airway responsiveness. And over the course of 45 years or so, this diagnosis or definition was really built up upon. And now we understand asthma to be a chronic disease that's characterized by these three different aspects here, including chronic airway inflammation, partially reversible airway obstruction, and increased airway responsiveness. These are the really big three hallmarks that really characterize our asthma definition as we know it today. And it makes us wonder, well, how exactly does asthma happen? Well, we know again that inflammation plays a huge role in the development of symptoms overall and what we see with patients who end up being diagnosed with this. So we can see here that the genetic factors and certainly environmental triggers do play a huge role in terms of triggering that inflammation. And then, of course, as a result of that inflammation, what we see happening is that hyperreactive or bronchial hyperresponsiveness known in the airway there, as well as that airflow obstruction that leads to the symptoms whereby most of our patients present with when we are seeing them, at least for the initial visit or even for subsequent visits when we are continuing to work them up. So again, it is multifactorial. There are a lot of different aspects that go into this, but just remember that the inflammation aspect is a huge part here. This slide is very important for us to really understand that whole inflammatory cascade. And it really does provide us a really good understanding, I think, of some of the newer treatments that we have available today, including some of the biologic therapies, which we'll touch upon in a bit. So just starting at the top of this slide here, which is known as the respiratory epithelium, we know that with a majority of our asthmatic patients, we do have some kind of trigger, whether it's a virus, a bacterial microbe, or an allergen, some type of trigger there that tends to provoke this whole cascade and lead to the symptoms that we see on the bottom of the slide here, including the thickening airway wall, that hypertrophy of the airway smooth muscle cell, that increased mucus production, and the overall airway remodeling, which includes what we know as fibroblasts infiltrating and proliferating in that airway, all leading to what we know today as asthma. So you can see here again, beginning with the triggers at the top, you can see various cells that make up our immune system respond to these triggers and then hereby use through these messengers or interleukins develop or provoke the increase in certain cell types like Th2 cells, which then go on through, again, these messenger immune type cells like interleukins to provoke the increase or formation of eosinophils and mast cells, the two big players, at least as far as we know, in terms of the T2 pathway or allergic inflammatory pathway, that then go on to initiate these symptoms that again characterize the asthma diagnosis. On the other side of the slide as well, we know that neutrophils are also a big player in terms of the non-type 2 or non-allergic asthma, which we'll talk about in a bit. But again, the point of this slide is really to just emphasize that there are a lot of different immune cells involved here, a lot of different interleukins. And again, when it comes time to therapies, we have a lot of really newer and evolved therapies that exist today that, again, can help us battle or at least treat asthma more effectively in some of our patients. So the National Asthma Guidelines really have progressed over the years, and the most recent updates that we've seen in 2020 have really tweaked what we were familiar with back in 2007 and even prior to that. So what we know now as really essentially the big features in these newer asthma guidelines are, number one, the intermittent or occasional use of inhaled corticosteroids. This also goes along with what is known as SMART therapy, or single maintenance and reliever therapy, which we'll talk about with our combined long-acting beta agonists and inhaled corticosteroid use. Indoor allergen avoidance and removal, allergy testing and shots, and fractional exhaled nitric oxide, or FeNO, measurements and monitoring. So we'll touch upon all of these again as they pertain to these 2020 focus updates. So in terms of optimal asthma care, what should you expect? Well, this again is a progression of where we should be evaluating patients and how we should go about initiating therapy and then assessing. So we usually start with that severity assessment. So again, history is a huge factor into assessing that severity level of the patient, so we can properly determine where to initiate treatment and really characterize, what type of asthma does this patient have? Is it a mild asthmatic? Is it a moderate persistent? Is it a severe persistent? Or are we dealing with an intermittent asthmatic? So we assess the severity here. We then go by starting therapy, and then, of course, with follow-up visits, assessing that control and adjusting therapy as needed, which again, we're going to delve into a little bit more here. So when we look at that asthma severity, again, it's really important to take into account the impairment or the frequency and intensity of the symptoms a patient may be experiencing at that time, as well as their functional limitations, and then also taking into account what's the future likelihood of asthma episodes, as we continue to follow these patients, and what is the likelihood of progressive decline in the lung function over time. We have to take all of these into consideration when we're looking at asthma severity, because they are all very linked together here. So in terms of optimal asthma care, the patient assessment is very important. Again, going back to that history taking and asking the appropriate questions. So in that assessment, we must delve into the patient history, or the presence of what we know to be as episodic symptoms that then influence that airflow obstruction or that hyperreactivity of the airway. Airflow obstruction, we know with asthma, exists, and it should be at least partially reversible in terms of at least using some of the short-acting beta agonists like albuterol and the other therapies we have available to hopefully, again, reverse some of that airflow obstruction that is present. And then again, in that initial patient assessment, and again, hoping to really optimize our overall asthma care, we should be taking into account some of the other alternative diagnoses and excluding them if there is any concern for that. So the methods for diagnosing the asthma, aside from the medical history, which again is a crucial element of this, the physical exam is very important, using objective measures, and then also some additional studies as necessary to exclude some of these other diagnoses. So when it comes to the medical history, these are some of the most important things that should be, again, considered in the questions that you ask. So what kind of symptoms is the patient exactly having, and what triggers these symptoms? Where has this development evolved from? Is it something new? Did it develop years ago? Have we been just dealing with an untreated disease for a number of years? What's the family history? This is very important, especially in younger patients whereby, there may be especially a maternal family history of asthma. We really take that into strong consideration here in assessing the overall asthma severity. What's the social history looking like? Is there any kind of trigger maybe at work or school or anything in the social life that is affecting the patient? This should again be really detailed in your assessment. Then looking at the history of exacerbations. Are we dealing with multiple emergency department visits or hospital stays, systemic steroid courses? We need to get a number on these, not just a yes or a no, but really a number and frequency so that we can better, again, characterize the severity of the asthmatic. What kind of impact? It's always good to know the impact of asthma on the patient and the family. How do they perceive what's going on with them? Are they identifying this as, what we are trying to lay it out for them as, or do they see it as something else? It's really good to get their perspective so that we can hopefully educate them to a better extent. Once the medical history is done, the physical exam is very important. So again, this really ties into assessing that severity For a lot of our asthmatic patients, that initial physical exam may be completely normal. Or you may be seeing somebody at the time of an exacerbation, and of course, you may detect certain things that would correspond with a diagnosis. But in any event, these are the three big parts of the physical exam that should be paid attention to. The upper respiratory tract, of course, properly doing an auscultation and listening for any kind of abnormal breath sounds like wheezing or decreased air entry, looking at the chest, and seeing if there's any kind of what we would say relates to increased work of breathing. Are they using any kind of accessory muscle use, things of that nature that would signify they're in some sort of distress. And looking at the skin, I mean, this would help us identify if there's any other kind of allergic trigger like eczema or atopy that may exist in the history, but again, would correlate with your physical exam. When we consider objective measures, there are a number of different things that may be done, but may not always be necessary in at least assessing the severity or even any asthmatic in general. But I think these objective measures, some of them certainly do help us at least assess in the beginning and also assess control following our initial assessment. So radiology studies like chest x-ray or any other type of imaging may be useful for some patients, again, if we're looking to exclude alternative diagnoses, but certainly is no reason, at least in that initial assessment, if we're highly suspicious for asthma, there's no major reason for us to just go out and order a chest x-ray for everybody. But knowing that that could be an option for those that, again, may have other things going on that may have an overlap with the symptoms related to asthma. Spirometry, a form of pulmonary function testing, is a really very useful objective tool here, at least in the clinic setting, for asthma overall, both in the initial assessment and also for trending a pulmonary function over time and monitoring that progression of any kind of lung decline as it relates to asthma. Again, using peak flow monitoring could be quite useful for some patients, even in the outpatient setting. I know in my particular practice, we do rely on spirometry more so, but just know that peak flow monitoring could be another useful tool even for patients outside of the clinic. Looking at allergy testing and doing proper referrals, if that may be a concern in terms of possible triggers that may be causing their symptoms. And then if needed, especially for a patient who is presenting in severe respiratory distress, considering something like an arterial blood gas or ABG to really give us an idea of their oxygenation and things of that nature to better assess the exact clinical status of the patient. And then again, using all of these things should really help us to exclude any of the diagnoses that, again, may have similar symptoms related to asthma. It's so important to remember that not every wheeze is asthma. So, and not even just wheezing, but even other symptoms that we may see in a typical asthmatic, could be, again, involved with a number of these different alternative diagnoses. So, we won't go over every single one on this list, but and it could vary from age group. But if you think about a pediatric patient, for instance, or even a young infant who's coming to see you, certainly thinking about congenital anomalies like congenital heart disease or vascular rings. Certainly in a young pediatric patient, a foreign body aspiration, or even anybody for that matter. And then even for older patients, taking into account things like allergic rhinitis or sinusitis that are not well controlled. Cystic fibrosis should always be a consideration. Of course, any kind of respiratory illness that may lead to bronchiolitis or bronchitis should also be considered too as an alternative diagnosis as well. So always keep these in mind because, again, we shouldn't always just jump to an asthma diagnosis before considering some of these other things that could possibly lead to this or lead to the symptoms that you're seeing. So there are many different types of asthma as we can think about right now. I mentioned a few of them earlier, like allergic asthma or non-allergic asthma. The rest of these on this list, I mean, you may see patients who may just be provoked by certain times of the day or certain symptoms that may lead to a more detailed or personalized asthma, I guess what you could call phenotype even here, as it relates to what you're seeing in the particular patient. So I think it's very useful to, again, not just generalize every asthmatic as presenting the same way and having the same symptoms or the same triggers. It's very, very important in that history taking to really get a good grasp on what is certainly leading to what the patient is experiencing. So once we do that severity assessment, now we're looking at starting therapy. So again, what we're moving more towards now is this precision or targeted approach. Previously, as you can see here on the slide, again, patients with similar observable clinical features were grouped and treated very similarly. But we've realized now that the major challenge is that a lot of these patients are not responding, or maybe they're not controlled on a therapy that we used to think was the standard of care. Essentially, one size doesn't fit all. So this evolving understanding now is taking into account a whole bunch of different clinical differences that may make a difference in the overall treatment response. So looking again at that genetic or family history, any kind of other underlying issues that may, again, cause some variations in the way a patient's responding to treatments. Again, we want to look at this from a larger perspective now so that we can really help develop a more targeted approach for patients with asthma. So again, the focus is shifting toward this identification of the mechanism. So rather than grouping everybody together and treating them the same way, whereby, again, we were looking at these observable characteristics on the left here, or the phenotype, we're now looking at what are the potential drivers of disease. So again, is this more of an allergic picture versus, certainly there is no allergy maybe in the history, and we're looking at more of a neutrophilic kind of an asthmatic. Again, we really want to try our best moving forward, now that we have the available tools, to look at what's known as the endotype, or what kind of pathophysiological mechanism may be explaining the patient's symptoms right now. So again, understanding these mechanisms can really help us provide a more personalized approach to our patients. Again, looking at this from the left and moving more towards the right, which is where we are continuing to go right now. We again understand that different treatments work for different patients. We really should not be looking at this as one size fits all. We need to really have that individualized treatment plan for each of our patients. It goes back to this discussion again on again providing that endotype for the patient in terms of understanding their symptoms and overall disease. Again, looking at it, I think from a broader perspective like this, is it type 2 versus non-type 2 inflammation? Very similar to the slide we saw earlier on in this discussion, whereby we know here at the respiratory epithelium at the top, if we're looking at the type 2 inflammatory pathway, there usually is some kind of trigger that's provoking the cascade here of different interleukins and cell types to then go on downstream to increase the number of mast cells and eosinophils that we know play a huge, huge role in type 2 inflammation and lead to what we see on the bottom here with a hyperresponsive airway remodeling, increased mucus production, and that overall smooth muscle or airway constriction and hypertrophy of the airway cells. So again, on the left here is this type 2 inflammatory pathway. And again, understanding that we do have treatments available to help really identify or at least go against some of these factors. I will even say, we'll talk about one of the newer biologics in the future here on one of the upcoming slides, but it goes against this TSLP. It's one of these players here at the top of the whole cascade here in the respiratory epithelium that, again, imagine blocking this, and now we're preventing this whole downstream cascade, and again, hopefully improving the symptoms that the eosinophils and mast cells would produce as a result of this downstream cascade. On the other hand, on the right side here, we have the non-type 2 inflammation. So again, some kind of trigger like an irritant, a microbe, or a virus may be provoking this non-type 2 inflammation, which is really characterized by neutrophils here that we see at the bottom. You can see, again, a number of different interleukins and players here that are involved, and again, may be very useful targets in the future for, again, this targeted approach or precision type medicine to help these patients improve in terms of their overall symptoms, if we understand their symptoms to be related to a non-type 2 inflammatory pathway. So again, I can't really overemphasize the understanding of this, especially as providers, so that we know how to better treat patients moving forward. So when we think about from a patient's perspective, well, what type of asthma do I have, or what type of asthma does my patient have? Again, if you're thinking of it, again, more of the type 2 versus non-type 2, we definitely know right now across the board that type 2 asthma is the more predominant player here, just given the number of allergens and sensitivities that a lot of people have. But again, also considering those patients that may not be responding to the typical therapies we use for type 2, and looking at some of the other factors that go into a non-type 2 asthmatic, like obesity-associated asthma or smoking-related neutrophilic asthma, knowing that a lot of different things could be triggering patient symptoms in the long run. So again, a nice overview here of this precision approach and really utilizing some of the biomarkers that are available today, like measuring eosinophil counts or looking at IgE or immunoglobulin E levels. Again, aside from what we can get from the phenotype or the history taking, looking at this endotype and utilizing the biomarkers that are available, utilizing things like a FeNO or fractional exhaled nitric oxide testing, this can all help us better tailor therapy to patients in the future and even right now. We must mention FeNO or fractional exhaled nitric oxide because this is definitely a great tool that measures inflammation in the airways. We know that it detects eosinophilic airway inflammation. It determines the likelihood of corticosteroid responsiveness. We know that it's a great way to monitor airway inflammation to determine the potential need for corticosteroid use. And it also is great for unmasking otherwise unsuspected non-adherence to corticosteroid therapy. As this relates to the guidelines that the 2020 focus updates, the big thing here is to use this really as an adjunct or an add-on type of objective measure rather than a straightforward diagnostic tool. We should not be using solely FeNO to confirm that a patient, is an asthmatic or is a type 2 asthmatic as it relates to eosinophilic airway inflammation. We should just use this as a tool to help us guide the diagnosis and also treatment in general. So once we start therapy, the next big thing that we need to consider, of course, is assessing that control and tweaking the therapy if needed. And again, using some of these other objective measures like we've talked about, like lung function, the asthma control test, of course. This can really help us really assess that control of the patient and how they're doing once they do follow up so that we can better determine if they do need a step up in their therapy or additional treatments added on based on what we're evaluating at these subsequent follow-ups. So the goal is really our control here. So the regular assessment and monitoring of these patients is crucial. Depending on the severity, you certainly may want to be keeping a close eye on these patients, at least in the beginning, once you initiate therapy, and making sure that these patients are encouraged to take their medication as prescribed, that we have a good control of their environmental and other health conditions, and that the patient and family is educated on the major highlights of asthma control, which we see down here at the bottom, of course. So making sure that patients are aware of their symptoms and certain times of the day, that maybe their symptoms are being provoked. What do they identify as their quick relief medications? What kind of daily activities may be causing worsening of symptoms? Certainly on follow-up, checking in and seeing, have they required any courses of systemic steroids or have they needed to be hospitalized or in the emergency department? These are all very, very important things that go into that control assessment so that we can understand whether or not a therapy adjustment needs to be made. The indoor allergen in terms of removal and avoidance here, this was also brought up in the 2020 focus updates. The key points here, of course, looking at things like dust mites, animal allergens, mold, cockroach allergens. We know that there are many, many effective strategies to avoid or limit the exposure to these allergens. But the recommendation here is that multiple strategies should be used at a time. There's really not just one particular strategy that should be recommended to patients. Usually when we're talking about an indoor allergen, there should be multiple ways to help guide patients to better control, avoid, and remove these kinds of allergens in the home. And again, we'll talk about adjusting therapy as it relates to that assessment of control, because that is a very, very big part there. If you have somebody who's coming back after 3 months or a month, let's say, if they're more severe, and they tell you they just completed a course of steroids or they were hospitalized or in the emergency department, of course, these are red flags that show that they are not well controlled whatsoever. So some of the newer trends in asthma care. I know these are things that are of great interest to all of us right now. We mentioned at the beginning, intermittent or occasional use of inhaled corticosteroids, smart therapy, the use of long-acting muscarinic antagonists or LAMA, allergy testing and shots or immunotherapy, and of course, monoclonal antibodies or biologic therapy to treat severe asthma. We know here, this is a very familiar chart. It's great to show patients who may not know exactly what medications they have been on or are currently on, especially during that first visit with you. It's great to show them this picture so that they can help better identify and help us get a better understanding of what they've tried in the past or maybe what they're currently on right now. So I always advise having something like this on hand. So let's talk about this intermittent or occasional use of inhaled corticosteroids, and is this treatment option appropriate? So for this really came out in terms of especially those patients even between 0 and 4 years of age. Initially, for intermittent symptoms, if that's what you were classifying your patient as initially, the go-to was a short-acting beta agonist or just using your albuterol inhaler as needed. Now, what research has shown and what the consensus has come to is that using both that short-acting beta agonist, beta-2 agonist, and the low-dose inhaled corticosteroid at the time of increased respiratory symptoms and using this for, a few weeks or so has been shown to help reduce the number of courses of systemic steroids, which of course is one of our goals in avoiding, and of course symptom improvement overall. So this has been something that I've been using in my practice. Again, for those patients who really are more of that intermittent classification, and it seems to work very well for them. Of course, if they continue to be using the inhaled corticosteroids on a more frequent basis, something isn't right here, and they certainly may need to have a change in their severity assessment and may need to be using these inhaled corticosteroids or whatever other kinds of treatment may be necessary for them for a longer period of time. But just know, for those with intermittent symptoms, this is a newer recommendation in terms of adding on the inhaled corticosteroid as needed with the short-acting albuterol. And again, why would this treatment option be appropriate for somebody? Again, the whole point here is to drive down that airway inflammation and hopefully prevent the systemic steroid courses and, of course, hospital stays and emergency department visits. Very similar here to SMART therapy or single maintenance and reliever therapy. The idea here is that instead of using the combined LABA or long-acting beta-2 agonist and the inhaled corticosteroid solely as your maintenance therapy, the thought here and the consensus as of the 2020 focus updates is to also use it as your as-needed reliever therapy. The issues that we will have to talk about with this, especially as it pertains to the United States, of course, is that unfortunately, the formulation of these combined inhalers is only enough for 1 month. So in my personal experience, we've been running into the issues of, well, if patients are using this on an as-needed basis as well, they may run into the problem and certainly running out of the medication, which we don't want to happen in the long run. So I think that's one big thing that needs to be addressed here, hopefully in the near future. But just know that this is a newer recommendation in terms of using the combined inhaler as both the maintenance and the reliever therapy. Of course, these are two examples, Symbicort and Dulera. Based on the age, the doses are very similar, 2 puffs twice a day. Spacers usually recommended, especially with these MDIs. But this is certainly two of the different options that may be available in terms of this SMART therapy. When we talk about the LAMAs or long-acting muscarinic antagonists, these are just a number of different types of the therapies available. In terms of the straightforward LAMAs like Spiriva, I know is a big one that I use in my patients 12 and above. And there also, of course, are combinations with LAMA, LABAs, and even triple therapies that we know exist for COPD patients for those older than 18. But just know that the LAMAs are certainly a recommended additional type of therapy, especially in those patients who, again, when you're talking about that stepwise progression of symptoms, maybe jumping from a step 3 to a step 4 and may need some additional form of therapy aside from just the LABA and inhaled corticosteroid. Certainly considering a LAMA is something to take into consideration. Allergy testing and shots. So the benefits here, we know these could be or could provide some small improvements in symptoms and quality of life, and also potentially reduce the need for long-term controller medication. Certainly, I think considering allergy testing and immunotherapy, if asthma is not well controlled on other medications, is something that should be held as a thought, especially if the history correlates with something like this. Again, the 2020 focus updates really did encourage that referral if necessary. And then, of course, the biologics. We won't spend too much time. Unfortunately, the 2020 focus updates really did not highlight the use of biologic therapy. And I presume, hopefully in the near future, we get some more consensus regarding this. But just know that these are the currently available biologic therapies in the United States for patients, and it varies with age. Some of them are for patients 6 and above. Others, again, you may need to be 12 and above, for instance, but it does depend upon what kind of asthmatic you're treating. I will say the majority of these are designed for a type 2 asthmatic. Again, some of those patients where you're doing the workup with biomarkers and maybe they have high eosinophil levels or increased immunoglobulin E levels, and they are uncontrolled on the current therapies, maybe even maxed out, of course, on inhaled therapies that are available. So, of course, the biologics are an area that have seen drastic improvement or made huge improvements in patients in terms of reduction of systemic steroid use, especially those that have been steroid resistant in the past, and even helping to decrease the number of inhaled therapies that are necessary as these patients do well or do better while on this biologic therapy. We talked about, I mentioned the TSLP biologic earlier, or Tezspire, tezepelumab. This is one of the newest ones out. Again, may be quite useful even in a non-type 2 asthmatic patient, given that the restrictions are less here in terms of not having or not requiring increased eosinophil levels, for instance, and helping to maybe treat other types of asthmatics that, again, are not doing well on current inhaled therapies. So again, the Biologics Summarized, a nice table here. I would just pay attention here to how it works. We see the different interleukins and immunoglobulins, or TSLP. These are the different approaches or what's being blocked by these different biologics out there. And again, usually used in a patient who is really at that step 5, step 6 progression therapy and not responding to inhaled steroids. Again, most of these are offered or given every 2 to 4 weeks. The nice thing lately is that a lot of them could be self-administered at home, but there is that option for patients to also come into the clinic as well if needed. But just know that these are definitely available if a patient is eligible. I think we're at the question and answer session here. I know we have resources to talk about. I hope I did okay with time, but I'll hand it over to Barbara.
You did fantastic. Thank you so much, Dr. Weinstock. This is a fantastic overview of sort of the trends in asthma care and where we are going. So I really appreciate that. All right, I'm going to try to take control of these slides. Let's see if I can do it. It won't let me.
Oh, maybe I have to stop sharing. Sorry.
I don't know if it's you. There we go. We'll see. No worries. Try that again. Thanks. It's coming back up for us. Perfect. All right, so as a reminder, if you would like to ask a question, you can do so by entering it into the Q&A box. For some of you, it sounds like some of you, for some of you, that Q&A box may not be available on your screen. So if you would like to ask a question, we invite you to raise your hand and we can take your phone off of mute so you can ask your question to the live audience. So again, if folks have questions, I do have a couple of questions that have come in. The first one is, my child's asthma is being managed by their pediatrician. I feel like it's not well controlled, especially after listening to today's presentation. Should I take her to see someone else for her asthma?
Well, I think that's a great question. And, you know, a lot of times what I will see is that the pediatricians are very capable of managing at least a mild persistent asthmatic. I usually say that if somebody's doing well on just a straightforward inhaled corticosteroid with no additional symptoms, I think that's fine being solely managed by the general pediatrician. Certainly when symptoms like you're stating and what you're describing here, if the symptoms tend to still not be well controlled, and maybe we need to step up therapy, I think that's always a great time to refer to a pulmonologist. And again, it does depend on the age, but if we're able to do things in our pulmonary office, like pulmonary function testing or spirometry, that could really, again, help us objectively identify if there are any issues or anything that we may be missing. I think it does help. And really, we look at things differently in pulmonary. And again, looking at a bigger picture, making sure that we're excluding any other diagnoses that may be present. So I think in your case, I think it would always, I think it, even for a mild persistent, let me put it that way, I think it never hurts to be referred over to pulmonary for at least an additional evaluation.
Fantastic. Couple other questions here. There's a question about a confusion between spacers and valve holding chambers, wanting to know if they're recommended for all medicines or which should I use it for?
So yes, the spacer in the valve holding chamber, basically very similar concept. What's happening there is that the delivery system is just more optimized in using them. And it does depend, of course, on which one the pharmacy is giving you, of course, in terms of the names, but the concept there is the same. They're usually designed for MDI inhalers or multi-dose inhalers rather than the dry powdered inhalers, which are the newer types of formulations out there now. The dry powdered inhalers are meant to, and you need to have a really good effort for them. They are meant to go directly into the mouth, and you need to have a really decent inhalation and good technique versus using something like the MDI with a spacer, whereby you really don't need to involve much effort whatsoever, but yet you still have that great delivery of the medication. So I always recommend, regardless of age, if somebody is using an MDI, it should be used with that spacer device, and it either has a mask or a mouthpiece for older people, and very easy to use and again very beneficial.
Great. Another question here. Are biologics available as shots only, and when should I ask for one?
Yeah, so most of the biologics right now are in a subcutaneous form, meaning it is a shot right under the skin. It's not a vaccine route like an intramuscular route, but yes, it is an injection. And usually something like this is considered for somebody, again, who is on that stepwise progression and not doing better on the inhaled medications that have been recommended. And if we know based on workup, that usually is done at that point in terms of looking at some of these biomarkers, like I mentioned earlier, the eosinophil counts or the immunoglobulin E levels, for instance, that could give us an idea and help characterize, is this an allergic type of asthma? Is it asthma at all? Is it a non-allergic type of asthma? Could really help tailor therapy, especially if the person is eligible of, like, meaning of age, or would meet the requirements if they do have increased levels of any of these things that I've just mentioned. So usually it is something that, again, is recommended when we don't have great control with the inhaled therapies. They don't work completely well for every single person. Again, it goes back to this precision or targeted approach. I think we do have to, again, do a better job of individualizing patients and making sure that this would be maybe the best fit for them if we're at that step where we need a biologic therapy or considering it.
Great. Another question here is, how do I determine my severity or control or type of asthma? I don't know, and no one has ever told me.
Great question. I mean, yes, until you have the person asking the right questions, it may just be a guessing game for you as a patient. So I think it really needs to be done, by a provider who is familiar in what questions to ask. Really, what I was talking about earlier, really getting a better idea of your symptoms and what you've tried before and how long this has been going on and what could be triggering. There's a number of different questions that could take up a decent amount of time in that initial patient interaction with the provider that, again, could help bring everything together and help us better assess the severity. Otherwise, if we haven't really looked at everything yet, and again, made sure that we've excluded other diagnoses that could be possible, it's very hard to say what your particular severity level is until we get a better understanding of all of that information.
I think related to that, there was another question in here about can my regular doctor, I'm assuming they see like a general practitioner, can they do these tests and prescribe these newer medicines?
Well, I think it depends on the comfort level of the provider. Certainly they can order, basic lab results. Like, I mean, when I mentioned an eosinophil count, that comes as part of a complete blood cell count, or CBC, with a differential, we call it. So it's very easy, and any provider can order these tests. It's knowing to order them and how to go about interpreting it. And usually, if there is concern whereby, is this something else other than asthma, or maybe there's just the provider is having a difficult time treating the patient, I think that really is a good time for referral to a specialist, just so, again, we could do the full workup and see if anything else is needed.
Great. And let's see if there's any other questions. I'll just put a reminder out there to folks. If you do have questions, you can do so by entering it into the Q&A field. If you don't see that option available, feel free to raise your hand and we'd be happy to call on you to answer any questions. Let me see. I have one more question in here. I think you answered the one about when to see a specialist, though I'm not seeing any additional questions at this time.
Barbara?
Yeah.
I apologize. It looks like we do have a question in there from Melissa.
Oh, great. Thank you.
And I'm happy to read that if you'd
yes,
like. Yes,
please do. Thank you so much.
How do you measure the eosinophil counts, and what is an ideal range for these values?
Yeah, so usually it's done as part of the complete blood cell count, or CBC, and it has to be ordered with a differential, we call it, meaning it breaks down in the CBC the different types of white cells, which is what eosinophils are. They're a type of white blood cell. And again, it does depend on the laboratory. They each have their own different types of cutoffs. In general, what in terms of numbers that we're looking at, again, the ranges that I look at, and again, that's standard across the literature, is that if you have somebody in a range of above 150, 150, and again, it does depend on the units, but that's usually the standard number. Greater than 150 certainly is reason to think, okay, yeah, this may be an allergic type of a picture. Certainly, when it comes to biologics, you will be, again, depending on which biologic you're looking at, most of them do require a cutoff, and it usually is around 150 or even up to 300. It does depend, again, on the type, but just know that, again, the laboratory has different, again, depending on which laboratory is running the test, does have different parameters there, but we can usually, there's some type of a formula whereby you can change it over to different units. But again, that 150 number is definitely something that we usually consider important.
Great. There's another question from Melissa, which I think I'll answer offline. She's looking just for some sort of the brand names for some of the newer medications. But that's a lengthy list, so I can probably connect with her offline to provide that list of medications. Right.
Like we have another question.
Yep, I see another question in chat. In what way do systemic steroids impact the body, specifically in a child at 9 years old?
Excellent question. So I know we're always talking about, okay, we want to limit the number of systemic steroid courses or limit them altogether. So I will say, in a short burst, let's say somebody's been on one burst in a given year, you're not going to see any long-term side effects. We worry about patients or people that are on steroids many times throughout the year, or we're having problems taking them off completely. So systemic steroids, so if these are things like prednisone, typically is a big one, or dexamethasone, they essentially have an effect on almost every bodily system, organ system, in a negative way. The big things, of course, could be weight gain, issues with bone mineralization. It could have negative effects overall on mental health, your endocrine system. A lot of different things can be involved here for patients who, again, are requiring multiple courses. And we're talking like upwards, 3, 4, 5 courses, or even, again, we can't wean people off of them. this is where we become very, very concerned and something is not right, or just the level of disease is very high.
Fantastic. I think that's it for questions. If folks have questions, please feel free to put them into the chat. I think what I'll do, just in the essence of time, is I'll talk about some of the resources that the American Lung Association has available to help patients better manage their asthma. And if we get any additional questions, I'm happy to pose them to you. So the first one I wanted to mention, because we talked quite a bit today about asthma control, and the American Lung Association has this helpful tool. It's a quiz. Take the assessment. Is your asthma under control? It's about 7 questions, really, really short, and it gives folks an opportunity to assess where they are in terms of their asthma control. At the very end, you get a nice summary that you can share with your healthcare provider to even start that discussion about, is my asthma being well managed, and am I in good control? So the link that is on this slide is a live link, so you can click on that page and just bookmark that. And we hope that you'll take a moment to check your asthma control and take the assessment. Another resource that the American Lung Association has available, we talked a lot about asthma medications today, and we've updated our series of asthma medication and device videos. So those are all available on our website. We have a dedicated page on how to use asthma inhalers and medication devices. So you can click on that live link. It's always a good idea to check your technique. And I think these videos will really help. There are downloadable instructions to go along with the videos as well, and they are available in English and Spanish. All right. I wanted to mention something that the American Lung Association has been working on in partnership with the Centers for Disease Control and Prevention. CDC has actually set up a series of strategies. They call them Exhale, which is an acronym. And they've compiled the best available evidence around improving asthma control and reducing healthcare costs. And the Lung Association is working with states to promote these resources. And so here are a few ways that you can implement some of these strategies, as someone living with asthma or as a caregiver of someone living with asthma. And the handy guide that's available on your page has lots of ideas to get you started. Here are a few. The first one being around education and asthma self-management. So you can get educated in asthma and asthma management. The American Lung Association offers the Asthma Basics online course. It's about 1 hour, and it teaches you everything you need to know about asthma. Another area to get better control of your asthma is to quit smoking and or avoid secondhand smoke and aerosols from e-cigarettes. Another strategy is around assessing your home environment for potential asthma triggers. Dr. Weinstock talked a little bit about how to remove some of those asthma triggers. And so we actually have some resources that can help you do that. So if your asthma is not well controlled, be sure to ask your doctor about assessing your home environment. And if you visit us here at the Lung Association's website, we have a number of resources that can help you do that as well. Also, taking your asthma medications exactly as prescribed, reviewing your asthma action plan with your asthma care provider at your next doctor visit, asking them to check if you're using your inhaler correctly. Make sure that your asthma action plan is available everywhere that you or your child goes. So making sure that you have one at home, one at school, one in your workplace, in case someone has to intervene in the moment that you have an asthma episode. And last but not least, check for protective policies at your school and work. And if you live in an apartment building, making sure that you're able to reduce your exposure to asthma triggers from indoor and outdoor and occupational sources. And there are some community resources to help. So we invite you to visit us at lung.org to learn more. There are several resources we have available to you, and these links are available for you to click on, but our asthma page on the lung.org website is a great place to get started to learn more about asthma. That's where you can access things like the asthma control assessment that I mentioned, as well as the severe asthma treatment planning tool. So walking through this training, this interactive model can answer a bunch of questions, and you'll get a discussion guide at the end of it as well. We invite you to visit our asthma resource library, where we have all of these tools, as well as the videos that I mentioned today. A few of them, just to mention, we have one related to getting ready for your office visit, something related to asthma medicine, your asthma medicine schedule, and lastly, your asthma action plan. Make sure you have an asthma action plan. If we did not answer your question today, feel free to contact our lung helpline. It is staffed by nurses and respiratory therapists and tobacco cessation counselors, ready to answer any of your questions you have about asthma or any lung health questions. And they can be contacted at 1-800-LUNG-USA. And lastly, I would just like to thank you for joining us for today's learning opportunity, Trends in Asthma Care. We would really appreciate your feedback, so please take a moment to click on the link provided on the screen today, or you can use your phone to take a picture of that QR code and complete the webinar feedback form. We appreciate your time. Thank you, Dr. Weinstock, for such an excellent presentation. I certainly learned a lot today, and thanks to my team on the back end for all your help and support for today's webinar. So this concludes today's webinar. Thank you and have a great rest of your day.